Hi everyone, welcome to the MIDAS Health Economics subgroup talk for the afternoon. I'm just going to wait another minute or so. I'll wait another minute because people are piling in at the minute. And then we'll get started and introduce Brendan. Just to let everyone know as well, the meeting's being recorded, and an edited version of it will appear on the MIDAS Health Economics subgroup webpage in due course. Well, I think we might get started, and then I can just introduce the talk. And because it's quite a tight hour, I know when people like to leave. I know these talks after at 2 o'clock on the dot, which is great. Okay, so welcome along. This is part of the ARC MIDAS Health Economics subgroup, long title, I know, series of seminars that we have. And at some point in the chat, we'll put the MIDAS subgroup website, so you can have a look at the older talks and all the other things that are on offer there. Okay, that we do. And every so often, Valeria will send a questionnaire around to the participants to see if you've got any other ideas for talks and different things that we can do. But we'll do that maybe next time, I think. Because today, we're very pleased to have Dr. Brendan Collins is here. Brendan works at the University of Liverpool and Public Health Wales. And this topic is going to be of great interest to ARC members and other people interested in health economics and the public sector, I'm sure. And we're very happy that Brendan came along to give the talk. Just in logistical terms, Brendan's going to give the talk for a certain length of time. And if you could put your questions in the chat, please, and we'll have a suitable amount of time at the end as well for you to ask questions live as well as we go. Is that okay with you, Brendan?
That's great, thank you.
We'll do it that way around. That's great, thank you. So I'll hand over to Brendan now, and thank you very much. And we'll do another thank you at the end, of course. But over to you, Brendan. We can see your slides really clearly. Thank you.
Great. Thanks, Bruce. Yeah, thanks everyone for joining this meeting. So yeah, I'm going to talk about using health economics in the public sector. So I gave a presentation last year I can't remember when it was, maybe November, for the Real Centre in York. And so there's quite a lot of overlap between this presentation and that. I made a deliberate, conscious decision not to watch that. I noticed that one's on YouTube now, so you can watch it on YouTube. But a lot of it's the same kind of material as this, but there'll be a few bits that'll be a bit different as well. So in this presentation, I'm going to say a bit about me, talk about policy interventions for health, talk about using health economics in local government and in the NHS, talk about using health economics in Welsh government, as in economics to COVID-19 policy models, working with UNICEF, so United Nations Children's Fund, around social return on investment, and talk about equity and MCDA, so multi-criteria decision analysis, talk about what I think are differences between social return on investment, cost benefit analysis and cost utility analysis. And then my idea, I suppose, of a way forward in terms of how health economics can help in driving policy by providing evidence for policymakers. And yeah, just a little disclaimer, these are my personal reflections and not the opinions of any organisations I work for or worked for. So this is me. I'm a senior lecturer in public health economics at University of Liverpool. I'm also currently working as head of health economics and modelling in Public Health Wales. So Public Health Wales is the public health organisation for Wales, so they provide leadership around public health, but they also commission and provide services as well. And so things I'm interested in are cardiovascular disease. So I've worked a lot with people like Simon Capel and Martino Flaherty here at University of Liverpool over the years. I'm interested in food policy, so I've worked on things like the sugary drinks tax and the 9 PM watershed for advertising on healthy foods, and I'm hopefully going to do other projects around food policy. We did a submission to the House of Lords thing last year around ultra-processed foods and costs of ultra-processed foods. I'm also interested in drug and alcohol treatment and prevention, so I'm on a project at the moment around preventing drug use in older teenagers. interested in cancer, dementia, global public health, and infectious diseases. So I did a lot of work around COVID during the pandemic. So pretty much everything. You can probably fit almost everything into there, and anything that's not in there, I'm probably still interested in it as well. So a little bit about me. I grew up in Norris Green, Croxteth in Liverpool, quite deprived part of Liverpool. Had a big heroin problem in the 1980s when I was growing up. I was one of 6 children. Got a scholarship to a private secondary school. I went to Liverpool Uni as an undergrad, so I always find really exotic ways of working out how long I've been at Liverpool Uni, but I should just remember that I started in 2000. So this year will be 25 years since I started here as an undergrad. And did the Masters in Public Health at Liverpool John Moores University, trainee analyst scheme, postgrad certificate in health economics at University of Aberdeen, did my PhD at Liverpool, and done a teaching qualification at Liverpool as well. So as I'll talk about, I've had quite an unconventional career. So I've worked in the NHS, I've worked in local government, I've worked in academia, I've worked in Welsh Government as a consultant for UNICEF, and now I work for Public Health Wales as well. I'm a trustee for Health Equalities Group, which is a Liverpool-based charity, which includes Food Active, Healthy Stadia, and other parts to it. We do a lot of advocacy work and a lot of work around improving wellbeing and reducing health inequalities. So one thing that happened to me was I was on holiday in Barcelona with my partner, and I saw this exhibition advertised, which was around big data. And I don't really know why I decided to go and go to this exhibition, left my partner because she didn't want to go to it, left her behind, and went to this exhibition. A lot of it was in Spanish. I don't really speak very good Spanish, but it was an interesting exhibition. It got me interested in big data. So then I wrote this paper on big data and health economics, which had quite a few citations. It was kind of a bit like an opinion piece. So I was very pleased that it got published. When I had my PhD viva a year or two later, one of my PhD examiners basically said to me that the reason that he passed me was because he read this paper on big data and it was a good paper. So I guess what I'm saying is sometimes these kind of random things happen in your career, and sometimes you need a little bit of luck, or sometimes you don't know why you're doing something at the time, but it pays dividends later on. So I think it's good sometimes you can see I'm the only author on this paper as well. So I think sometimes it's good if enough people tell you that something's a bad idea, sometimes it's worth doing anyway on your own, I think. So I'll talk a bit about doing health economics in the NHS. So I worked in the NHS quite a lot in my career, in my Public Health Wales as part of NHS as well. And I think doing health economics in the NHS is tricky. You can kind of get involved in economic evaluations alongside trials or whatever, but actually doing it just with the data that the NHS has got, it doesn't always have a lot of outcomes data, or you don't always have access to it, or it's not routinely collected or in a systematic way. I mean, there is quite a lot of EQ5D is the main thing that we would use to estimate QALYs. There's quite a lot of EQ5D data collected for various things in the NHS, but it's not always available, or it's not always collected in a systematic way. You can look at outcomes like hospital readmissions or mortality. You could look at QALYs associated with diseases. So if you're looking at prevention, you can use estimates from the literature around QALYs from diseases. A lot of work that I did when I was in the NHS was looking at things like NICE costing tools. So NICE I don't think they produce costing tools anymore, but they used to, when they were recommending new things for the NHS, they used to produce these kind of costing tools. So a lot of work, which I found really useful. I mean, I'm guessing that one of the reasons they don't produce them anymore maybe was they felt that people weren't really using them very much, but I found them really useful. So a lot of it was looking at those and kind of interpreting them locally for like new interventions. So one thing that I looked at, say, was ticagrelor, which was a new drug. You can definitely do simple cost comparisons. So NHS in England has got good quality cost data, but there aren't that many. I would say there's not that many health economists working in the NHS locally, or or working in local governments on health stuff either. I think there's probably quite a few in like NHS England, or people with a health economics background in NHS England. So using health economics in local governments, I worked in East London for a while, worked in Wirral for quite a long time. I'm now involved with the Liverpool Health Determinants Research Collaborative. So there's a set of these HCRCs that have been funded by NAHR, which is around, I guess, upskilling local governments in terms of their ability to use research and to produce their own research, and focusing on wider determinants as well. So looking at the relationship between things like housing, employment, education, and health outcomes. I think there's quite a small number of health economists in local governments. You can definitely count them probably on one hand, but there are health economists who work with local governments a bit more or might have placements. And I think that there are real opportunities, I think, for health economists to work with local governments. So a lot of the work that I did was evaluating local public health programs. So things like smoking cessation, drug and alcohol treatment, weight management, health trainers, sexual health services, neighbourhood investments. And it was sometimes producing like bespoke models, but quite often using existing return on investment tools that have been published. I think there's not as many of these tools, or the tools that were around have not been updated for a little while. So I think there's potentially a bit of a gap for these kind of tools to be produced. And I think if people are producing research around public health interventions, then producing these kind of easy to use tools, I think is something that would benefit local governments. And a lot of the work that I did was informing a commissioning process, which was a kind of often a 3-year cycle, but sometimes services could be rolled over for 1 more year or 2 more years. And a lot of times it was looking at changing the provider for services. So doing a bit of economic evaluation, maybe finding that provider wasn't working as well as they were hoped to, and then it would be recommissioned. So I think when I would be going out to services, they would kind of see me as a sort of the angel of death for them. Like if I was evaluating them, then often it was seen as pretty bad news, really. And I don't know how much I agreed or believed in this kind of NHS or sort of local government commissioning cycle, public health commissioning cycle. I think sometimes services needed a bit longer, really, to start producing results. And I kind of feel like sometimes it's, you want to stir the coffee before you add more sugar. You don't always want to keep changing things, whereas having those roles in terms of commissioners in local government maybe creates an environment where they feel like they need to be recommissioning all the time. So other things that I worked on were around kind of NHS service redesign. So looking at things like urgent care, looking at local sustainability and transformation plans. So trying to produce some economic evidence for those kind of plans, like things like hypertension, better management of hypertension. What was the cost effectiveness of different interventions for that? So using existing evidence quite a lot and then looking at cost effectiveness. And a lot of work that I did as well was around prioritization. So we used multi-criteria decision analysis in terms of prioritization for public health services and council services. So I mean, this is something that, it is a kind of economic method, but it's a bit more subjective as well than typical economic evaluation. So yeah, in local government, we quite often use these national social market incentive value for money tools, which you can still find them online. So Graham Lister, who produced a lot of these tools, you can get them on his website, but they've not been updated for a little while. I think there's potential to update these kind of tools, and I think they can be useful. So there are a lot of them around behaviour change, so things like smoking, weight management, diet and activity, physical activity, alcohol, breastfeeding. So I think there's potential for more of these tools. There are some of the tools that have been produced more recently, like Sheffield University produced diabetes prevention program tool. I think there's challenges with these kind of return on investment tools. So some of the work that I was doing for UNICEF was trying to produce a new one of these return on investment tools for interventions around overweight and obesity in low and middle income countries. And I think there's data requirements. So what kind of data do people need in terms of the outcomes from an intervention or the outcomes from a service? The technical skills required to use a tool. So you might produce a tool and think it's relatively straightforward or relatively self-explanatory, but it's whether people need those kind of technical skills. I think there's trade-offs around granularity versus simplicity as well. So you can have something that will work with really granular data. So it might be, almost like individual level data for a service, but some people won't have that type of data. So having a simple tool where you can just plug in numbers and say, well, we had 400 smoking quitters this year. This is what we think the cost effectiveness of that intervention is based on, the average benefits to people rather than the age specific benefits or, gender specific or for specific ethnicities or whatever. So I think maybe having 2 versions of a tool or a sort of simple version and an advanced version can help sometimes. There's issues around shelf life. So if it's based on data as of now, then what is the shelf life for a tool? Or is there a way to have tools that automatically update? For instance, if the epidemiology updates or the economics of a particular issue update over time. And then I think there's challenges in terms of explaining results to decision makers, and particularly if you've got benefits that fall to different parts of the economy. So quite often what you get with public health interventions is this kind of cross-sector flow problem where you spend money in one sector of the economy, but you get benefits somewhere else. So explaining the results and having results that are relevant to different types of stakeholders, I think, is important. So a lot of the work that I did in local government involved modelling. So there's this question around, should local government create economic models themselves? Or, you know, a lot of the time when I told people what I was doing, and it was the work that went into my PhD as well. So it wasn't just for, just for local government to use, although hopefully they did find it useful. But people would say, well, how can one person be creating like a health economic model? You need a big team to do this. Or it should really fall to people like NICE to be doing this kind of stuff. So I suppose I learned a lot from doing my own models from scratch, and I'd definitely recommend having that experience of doing it. But yeah, there's that question about who should be doing stuff, I guess. And I think having a federated model where maybe different local authorities with expertise could lead on different things or have a shared modelling platform would be useful. I think it's useful to have basic estimates of the value of different outcomes. So, and these are hypothetical, but if we know that the average benefit of a smoking quitter is £5,000 or whatever, or for a person who's no longer obese, it's £10,000. I think some of this kind of evidence does exist in different places, but I think even some of this stuff is quite useful for local public health services to understand a bit of the value of what they're doing, because it at least gives a ballpark figure of, if a service is costing X and they see 2,000 people per year, then what is the relative value of it? And I think having tools that fit around routine data collection that's used in public health and social care. So if we've got local public health services, how do they collect their data? What does it look like? What do they have and what do they not have? Because that's what we need to fit those kind of tools around. And I think we need more around wider determinants, so things like health and housing. So there's projects like Trude producing tools for this. So they produced a house tool, which looks like it will be useful for those kind of things. So this is an example of kind of modelling that I did when I was working for Wirral. It looks very complicated, but it's mostly kind of lots of routes in and lots of routes out. So it's in Simulate this model. It's looking at drug and alcohol treatment. And these are some of the outcomes that we had from its output. So things like it was looking at costs and qualities for structured treatments for opiate users. And then we modelled, looking into the future, how many opiate users would be completing treatment based on current levels of throughput and the amount of time that people spent in services. So it's partly trying to predict the future, but also looking at cost effectiveness at the same time. So I think what I kind of moved on from sort of doing local interventions was thinking about policy interventions to improve health as well. So I got involved in this work around the sugary drinks industry levy, or the sugary drinks tax, and started by producing a tool for North West England, and then it became a national level tool. And it was a pretty simple model really that it was based on, and there were people who did much better, more sophisticated models than what I did. But I suppose because it had results for each local authority in England, it was used as a tool by Sustain to advocate for the sugary drinks tax, which actually happened, which I was very surprised when it happened, to be honest, when it was implemented by the previous Conservative governments by George Osborne and people. So yeah, that was a surprise really. So I think, in a way, making that case maybe helped in terms of advocacy for those kind of policies. And I think that I'm very interested in food systems, and I think food systems have a huge potential to make a difference in terms of people's health. So policies to create a healthier food system. So not only punitive stuff like taxes, but incentives and ways that people can get affordable fruit and vegetables and seeds and nuts and things like that in the diet, I think can make a big difference. So I also worked in Welsh Government for 4 and a bit years. So the main work that I did around health economics in Welsh Government, I went there as head of health economics, but about 6 weeks later, COVID happened, and I ended up kind of leading on COVID modelling for most of the time I was there, and then got more into infectious diseases modelling as well. I mean, I still wasn't the person doing the really clever stuff, so it was colleagues, people at Swansea University, for instance, who were doing the really clever stuff, or other people in my team who were doing the really sophisticated modelling stuff. But I guess I got a bit of an understanding of infectious diseases modelling being in there. But aside from that, which I'll talk about in a bit more detail, the other stuff was things like impact assessments. So I think people outside of government, they might be familiar with cost benefit analysis, but they're not always too familiar with impact assessments. And I think impact assessments are a good thing for people to get familiar with. Also things like business cases, prioritization. So we were using methods like program budgeting and marginal analysis and multi-criteria decision analysis. And I think a lot of these things get used, but maybe it doesn't get published. It doesn't really make it into the published literature very much that these things are being used in government. So I suppose it's making people aware that these things are used. And there'd be things like government investments. So, if someone's building a new ice cream factory in Wales, does the government invest in that, considering if it's an unhealthy food, for instance? So inputting into those kind of decisions was interesting. And then thinking about relationship between health and other outcomes. So I worked sort of across between sort of health and treasury, like Welsh Treasury. And so I was thinking about relationship between health and health-related worklessness in particular, but thinking about things like deaths of despair. So deaths related to alcohol and drug and suicide. So I think the main skills for working as a health economist in government, I think you need things like diplomacy, build credibility, show people what you can do. I often talk about like academia as being a pyramid scheme where you sort of have an idea, get someone to give you some money, and then find someone to do the work. And I think government's a bit like that as well, in terms of if you can be the person who can actually do the work, then you'll definitely be in demand. I think a lot of government work is like rapid evidence synthesis, so rapidly understanding what's going on around a topic or what the economic evidence is telling you around a topic. I think understanding new topics quickly is really important. And having a broad understanding of research and evaluation methods is useful. Being able to lead teams, switching between topics and working quickly, I think they're all important skills. I think I'd encourage people to look at opportunities to work as a health economist in government departments if you can, because I think it's a really fun thing to do, and it's really different, particularly if you're someone who is a bit of a magpie who likes switching between lots of different things quickly, then it can be a fun thing to do. So during the COVID-19 pandemic, I led on modelling and advanced analytics as part of the Welsh Government Technical Advisory Cell. So Welsh Government had devolved powers around stay-at-home orders, etc. So there were times when Welsh Government policy diverged from the policy of the UK Government in Westminster. So as part of this, I kind of put together a team of 8 to 12 people, a mixture of different sorts of disciplines, linked in with academics in Welsh universities, particularly Mike Gravener at Swansea University. And so part of my role was presenting to policymakers and ministers in Welsh Government and attending national groups, so presenting on what was happening. I think providing scientific advice in emergency, you've got this kind of handshake between research and policy. People in the past would talk about sort of thinking fast and slow, that policy often might move fast and research might move slow, or maybe it's the other way around, maybe policy moves slow and research moves fast. But I think it was thinking about how do we use evidence and recognizing where evidence doesn't exist, using evidence in a different way. So you think about face coverings, there wasn't a lot of sort of evidence-based medicine type randomized controlled trials around face coverings, but some of it is around the physics of it and things like that. So, and I think that's true working in local government as well. So a lot of people might come from a more of an engineering background rather than a health background. So that if you want to build a bridge, you don't do a randomized controlled trial and build 2 bridges and see which one falls down. You understand the physics and get the physics right first time. So it's understanding different types of evidence. So we had this idea in Welsh Government. Well, it wasn't just our idea. There's different definitions of the 4 harms, or we had the 5 harms. So we had sort of direct harms, indirect harms due to pressures on healthcare systems, harms from population health measures, so lockdowns, stay-at-home orders, economic harms, and then the 5th harm was around inequality. So that was kind of like a cross-cutting harm. And a lot of decisions were trying to balance these 5 harms, really. So a lot of times, during the pandemic, there's not one perfect decision that's going to not harm anyone. So it's thinking about balancing these different harms. And we had a socioeconomic harms subgroup that was chaired by the chief economist. And I think what the issues were around sort of data is that data on different harms is on different schedules. So you might have data every day about how many COVID cases you've got, how many COVID deaths, but you don't have data on economic indicators every day. There might be some stuff you can get, like footfall data from Google, or credit card data on how many people are shopping in different places, but most data on economic indicators is quarterly or even less than that, so you don't always know what's happening to the economy at any time. And in Wales, we've got the Wellbeing of Future Generations Act as well, which requires public bodies to think about long-term impact of decisions. So COVID was a syndemic. So a syndemic is where you've got different risk factors or diseases that combine in a negative synergistic way. So there are different types of risk factors. You've got clinical, behavioural, place where people live. And there's different theories of inequalities as well, how they happen. I think that COVID was a story of if you had a house, if you had a garden, if you had a car, you had money in the bank, you were in a stable relationship, then it was a different pandemic for you than it was for people who don't have those things. And there were shadow pandemics that were hidden by the main pandemic. So shadow pandemics of violence against women and children mainly. So one thing that I tried to do quite early during the pandemic was add economics to epidemiological models. So a lot of the criticism of COVID responses that I focused too much on sort of epidemiological outcomes like cases and deaths and hospital admissions rather than broader economic outcomes. So it wasn't balancing these things up properly. And I think really decisions should be based on integrated impact assessments. So this is where costs and benefits are quantified as best as possible. In Wales, we quickly included health economic costs in our models that we were using. So we would have costs of hospital activity and estimates of QALYs. Initially, we used QALY estimates for most similar diseases where they didn't exist yet for COVID. So we'd use pneumonia for COVID admissions, we use asthma for community cases, and we use moderate fibromyalgia for long COVID. So this is based on clinical judgments. I think that, yeah, we did include long COVID from quite early as well. So, I mean, a lot of COVID sorts of economic models didn't really include long COVID, or I think they didn't include it sufficiently. So they'd only included it for people who'd previously been hospitalized. They didn't include it for community cases. And sometimes I think long COVID can make quite a big difference in terms of the costs and benefits of different scenarios or different strategies, say around vaccinations. We also work with Welsh Treasury to estimate GVA losses associated with different levels of restrictions. There was also evidence around stringency of measures versus GDP GVA loss, but it's more difficult to estimate the longer term economic impact. So you think since COVID, we've had Brexit, we've had war in Ukraine, we've had Liz Truss, so we've had a lot of things that happened to the economy since COVID. So all of those things contribute. So it's hard to understand what impact COVID alone had on those things, I think. And I think considering the trade-offs, it's partly a kind of technical process. You can present a lot of data, but it's partly a subjective process as well. So people will have their own emotional response to things and their own views about things. And the value of a QALY makes a big difference. So you probably know that UK Treasury value QALYs at £70,000. So a few years ago, at the time of COVID, it was more like £60,000, but still a lot higher than what the health reduction cost in the NHS might be, or what the NICE threshold is. So NICE threshold is usually quoted as £20,000 to £30,000. And you've got interventions in complex systems. So individuals are changing their behaviours versus government intervention. So you look at what happens in different states in the US. In the US, where states didn't have sort of lockdown type measures, so where they were more relaxed in terms of the measures, people still changed their behaviour. People still weren't going out shopping and things like that. So people will change their behaviours in the absence of those kind of interventions. So this is an example. This is published of where we looked at using models and comparing it with and including economic outcomes. So we had different scenarios. So this is looking at different levels of intervention. And then we had healthcare cost savings, QALYs gains, and then we had incremental net monetary benefits. And then we had estimates of GVA loss, and then the overall net value. So I'd say it wasn't perfect. There's probably a lot of things that were missing from this, but it was an attempt to look at the net value, considering GVA losses and considering the value of health. Now you can argue that we can't value health in that way, but I mean, I suppose most people on this call are health economists. That's what we do, isn't it? Right? So there is possible to put a value on health, and the question is what should that value be, I guess. So that's an example of how we tried to combine sort of economic modelling and epidemiological modelling during the pandemic in Wales. And I think considering these type of economic impacts might be important in a range of emergencies. So there's estimates of economic impacts of war in Ukraine and things like that. So I think that these kind of methods will become more important over time. Obviously, putting a price on human lives is difficult in terms of ethics, etc., but that's what we do in health economics anyway. Yeah, so yeah, and I think it was quite a sort of interesting and important thing to try to do as well, and it was something that wasn't done. I didn't see it done as much as I would have expected, actually. So I don't know if there were any health economists on stage, for instance, during the pandemic. So that was working in Welsh Government. I did quite a few other things in Welsh Government, but I thought that might be quite interesting. I've also recently worked with UNICEF, so I found out about this work through previous work with colleagues that I've worked with. So I worked with Graham Lister, who's a health economist, And this was a different audience. So it was to inform UNICEF, but it was also to influence donors, really. So people who donate money to UNICEF. And I think that people donate money, it's quite easy to make a case that if you've got children who are starving, who are malnourished, or mothers who are malnourished. But what we're seeing as well is this kind of triple burden of malnutrition happening in a lot of countries around the world, where you've still got undernutrition in early years, but you've also got an increase in overweight and obesity in later years, sat alongside nutrient deficiencies as well. So things like iron deficiency, anemia in particular. So it was looking at interventions around this kind of triple burden, and it was focused on interventions in Zimbabwe and South Africa, basically because they had the best data, and there were real challenges around getting good data for this work and the evidence base as well. I was shocked at how little evidence really there is around interventions around overweight and obesity in low and middle income countries. So I think that's a real gap, and it was quite an eye opener for me as well, because often in the UK, there might be multiple studies looking at similar interventions, but in low middle income countries, there's a real lack of published research anyway. There might be a lot more sort of evaluations and things like that sit in grey literature, but it was hard to find much on these things. So there's the main stages to this project. So yeah, it was more like a social return on investment type project, which, I know health economists may frown at social return on investments as not always being very robust, etc. But I think it has potential value for some things as well. Yeah, so this was the process that followed for this piece of work. And then this is just an example of the type of outputs that we had from it. So it was looking at benefits by sector. So kind of, you could call it SRI, it could be social cost benefit analysis. So we had the value of health benefits. So this would be disability adjusted life years. You had government and health cost savings, productivity, employment benefits, some modest environmental sustainability savings from people moving from a kind of UPF diet to a less processed diet. Probably the true environmental benefits might be a lot greater than this. And then we have other benefits like well-being and education. So if children are more likely to be in school because they've got school meals, for instance, then there's economic benefits in terms of education. So that's the kind of thing that I was trying to move towards, and I think this is the kind of thing that I would like to see a bit more, I suppose, is thinking about how do we look at have this broader approach to looking at benefits. So, you've got classic health economics type methods, but I think having this broader perspective is really useful. There's also methods like distributional cost effectiveness analysis that I've used a bit more. I feel like it's not being used so much in local or national governments. There's work that NICE have been doing recently around, which I was involved in a little bit around, inclusion equity in their submissions and things like that. And I think there's probably more potential to link in DCA with things that they do use in governments, in both local and national government, like equality impact assessments. So including DCA a bit more in those kind of things. So if you're not familiar with DCA, and hopefully probably quite a few of you will be, there's things like the equity impact plane. So we've got the classic cost effectiveness plane that we use in health economics. Equity impact plane is similar in terms of we've got cost effectiveness on one axis. So this will be a summary measure of cost effectiveness. So the classic cost effectiveness plane, you've got costs on one axis and benefits on another axis, which might be qualities gains or whatever. In this, you'll have a summary measure, which might be total net health benefit or total net monetary benefits. And then you've got a health equity impact on another axis. And I think there's a bit of debate around what should be the win-win quadrant, but typically I think it's this northeast quadrant is the win-win quadrant, whereas, as you know, is it northeast? Yeah, northeast quadrant. Whereas typically, as you know, for the cost effectiveness plane, it's normally the southeast quadrant that's the win-win quadrant. That's the dominance quadrant. And so this is an example of where we looked at different scenarios on an equity impact plane. So this was looking at net health benefit and inequality reduction for 3 scenarios around NHS health checks, which is CVD health checks that people get from like age 40. And so we had a current implementation, increased implementation, and then targeted. So targeted was the only one that was on this kind of win-win plane, where it was both cost effective and it was reducing health inequalities. And so I think there's real promise to use this more in NHS and local and national governments. So probably, trying to sell this to people, I think is quite important. And I think thinking about this overall, what we want to have is a win-win portfolio of interventions. So not all interventions are going to be a win-win. Some interventions are going to benefit more affluent people more. But I think if we aim for a win-win portfolio of interventions, then at least we're kind of heading in the right direction. So another thing that I've used quite a bit is multi-criteria decision analysis. And I think this has been used increasingly by academics and in governments. It's been criticised sometimes as not being robust, for instance, because of overlap between different criteria. I mean, in the past, what I normally do is I look at the correlation between different scores on different criteria to understand if they're likely to be measuring the same thing. I mean, that's probably quite a simple way of doing it. There's probably better ways to do it. But I think it is possible to control for some of these issues. And I think that MCDA has got promise because it adds some rationality to the way that decision makers weigh up decisions in the real world. So if you've got a committee of people who are there to make a decision, then they're going to have their own biases and their own way of doing things. But if you can kind of get that down on paper and quantify it where possible, then I think MCDA has got promise in terms of that. So UK Treasury have produced guidance around MCDA. They say that MCDA can't replace cost-benefit analysis. And they say that swing weighting and rigorous sensitivity analysis needs to be included. So this is UK Treasury process for MCDA. So you can see, I suppose the main thing with MCDA is it should only be used where you can quantify things on a scale. If you've got something that's like a yes/no question or something that's a must-have, then MCDA isn't the right method. But it's more where you've got different options where you can quantify, and it's based on the principle of that you can kind of compensate for a low score on one thing with a high score on something else. So, you know, if you're looking to buy a house, you might want a big kitchen and you want a big garden, but it might be that you can compensate for a smaller kitchen with a bigger garden or vice versa. Then you could do a little MCDA on the houses that you look at. But if something's a must-have, then it wouldn't be MCDA. That wouldn't be the right method for it. So this is an example of criteria that we might use for kind of health investments. So we would have a weighting for different criteria, and then you'd score different options against those criteria. So you might have something like fit with priorities and policy, clinical impact, value for money, statutory compliance and risk, equity and community benefits, and then wider benefits and climate change. So what you'd have is a set of criteria that you judge things on, and then you'd have weightings for those criteria. So some overall observations and recommendations from my work so far. So I think return on investment for public health interventions is often much greater than clinical interventions. So there's this paper that I'm on where the overall return on investments, and it's not just the financial return, so it's all different types of returns. It's the value of health, etc. The median was around £14 for every £1 spent, and this paper is the gift that keeps giving because it's been cited lots of times, which is great, and we're looking to update it at the moment. I think thinking about the differences between cost-benefit analysis, social return investment, health economic evaluation. So, I mean, this is my own interpretation of it, so people might have different ideas of it. But I think thinking about who your audience is. So, if you're doing something for government, then you might not want to do a kind of classic health economic evaluation. You might want to do more of a cost-benefit analysis or something that would sit within an impact assessment. So I think social return investments or return on investment maybe is more for sort of donors or investors or commissioners. But there's a big move towards wellbeing valuation as well. So a lot of it's moving in that direction. And there's different guidance. So there's an SRI guide, there's UK Treasury Green Book for cost benefit analysis in the UK. There's different guidance for health economics. So you've got a second US panel, you've got nice guidance. And I think in a world of perfect information, we would know what the incremental costs and effects are for a program or an intervention over a long time periods. These different methods, I think, are different in terms of how they deal with that information problem, maybe either having short-term follow-up or having imperfect information. So SRI usually has a long list of outcomes, but it's often maybe a small scale, uncontrolled before and after type study. So it might measure the same outcomes in people over time, but you don't know what the counterfactual is. Whereas say for health economics, it might be done alongside the trial. So those methods might be robust, but you might have quite a small set of outcomes. It might even be that the health economist doesn't have a lot to say. They might say, oh, it includes a bit of EQ5D. We'll try and include some costs, but the CSRI takes us too long to do, so we'll do something else. So it might be that in the health economist doesn't have that much power in terms of what's included in the trial. So you've got a small set of outcomes, but better methods. And there's been research in the US that looking at cost benefit analysis that suggests that they're not systematically optimistic or pessimistic. So most cost benefit analyses are done prospectively for future interventions, whereas say health economic evaluation can be prospective modelling, but quite often is retrospective, looking at something that's already happened. So I think there's issues with government versus health perspective. So what value of QALYs do we use? What benefits should we include? Should we move more towards wellbeing valuation? So there's estimates of the value of wellbeing adjusted life years. I think we need more kind of off-the-shelf tools and data and estimates. So if you're doing a study of a public health intervention or a policy, then having something that's easy for policymakers to pick up and use, I think, is really important. Potential inconsistencies with different health interventions. So vaccine impact assessments use JCVI, incremental cost effectiveness ratio of less than 20k per QALY, whereas other impact assessments use different values of QALYs. There's examples, say, of varicella vaccine, which was recently recommended. Now, the biggest impact of varicella is probably productivity. It's probably parents being at home looking after their kids when they've got chickenpox, but that wasn't included because it only has a health perspective. So I think it's thinking about what are the most important impacts of different policies and interventions, and how do we include that in whatever piece of analysis that we're doing. So in terms of tips for working with policymakers, I think it's good to try and find people in government, or they might find you. I mean, when I worked in government, I always found like academics really responsive, which was great, a lot more than academic to academic. I think if you can aim for short summary of your work, like short policy briefings are really useful. I think sometimes in academia, we kind of laugh about having to do policy briefings, or we think that they won't really be picked up. But I think if your work is important enough to influence policymakers, then they can be really useful. And I think there's issues around communicating the uncertainty, and health economists are good at visualizing uncertainty, like with methods like tornado charts. So I think sometimes in government, that particularly say during COVID, that people would think that uncertainty means that you don't know what you're doing, rather than there being sort of inherent stochastic uncertainty with anything really. So I think explaining uncertainty is really important. I think if you want to influence government, then try and do cost benefit analysis rather than health economic sorts of methods that with QALYs and things like that. And I think having a user interface where someone can easily vary or update the parameters is really useful. I think other evaluation methods have got things to teach us in health economics. So I think SRI has got a lot to teach us about stakeholder engagement and understanding which outcomes are important. I think realist evaluation's got a lot to teach us about understanding the influence of context, and there's a burgeoning field around realist economic evaluation methods as well. So you've probably seen this kind of health economics value flower of, the things that are usually included in health economics, and then other things that are not always included. And some of these, I think, are similar to what you would have in a cost benefit analysis or social return on investment analysis. So what should the way forward be? I think we need more about macro health economics. So how do we create a healthy system? What does an efficient health system look like? How do we maintain a healthy workforce? What kind of preventative interventions should we invest in? But don't forget this, maybe smaller issues like behavior change, training, oversight, quality of care. All of these things matter. And I think people outside of health economics, or people outside of economic evaluation, probably don't realize how much overlap there is between different methods as well. So sometimes you can reorganize your outcomes from different methods and use them for different things. I think we've got an interesting time around QALYs in the US as well, which isn't, that started last year. It's not even like a thing since Donald Trump, that kind of QALYs have been outlawed a bit in the US, and how they're used in cost benefit analysis is they're looking at using the sort of the utility values on their own, rather or using years of life lost on their own, rather than using the QALYs altogether. And I think there's questions around, should prioritization methods be seen as part of health economics as well, or is it a separate sort of field? These are what I would say 3 priority areas for health economics and government. So I think having an efficient NHS, having a healthy workforce. So that means the whole workforce, not just the health workforce, but having a healthy, productive workforce across the whole of society. And I think prevention on an industrial scale as well. So how do we do prevention on an industrial scale? And yeah, so I've said a bit about impact assessments. I think if you want your work to influence government policy, familiarize yourself with what impact assessments look like and how they show cost benefit analysis. So you've got an example there on the right of what an impact assessment looks like. And you can see sometimes people do talk about impact assessments, especially if they're not done. So there was like Rishi Sunak asked questions to Keir Starmer about winter fuel payment cuts and whether there was an impact assessment. Apparently there wasn't. So I think economic perspective that you choose should depend on decision maker and stakeholders. I think most of the time, if possible, includes as broad a perspective as possible. So include things like productivity, informal care, environmental impacts, educational impacts, well-being, equity where possible. But doing this is challenging. I think I've said a lot of this stuff already. Yeah, I think using economics and modeling is most valuable where there's a genuine decision question. So not simply to say, oh dear, or that's nice. I think where you've got a genuine decision question with different options is where you get most value. And I think use of health economics in government will depend on understanding of its potential and also how technocratic government is. So how much they're going to listen to evidence when they're making decisions. But yeah, in my experience, health economists are usually very wise people to work with. Yeah, so I'll stop there and take any questions. Thank you.
Thanks very much, Brendan. That was fantastic. I've got lots of questions, but there's one in the chat. Can you see the chat, Brendan? Or I could just ask Dougal if you want to read it out or summarize it.
Okay, cool. So yeah. So are there any social value databases or tools that have been rigorously validated? At Cornwall Council, we're exploring various options to improve how we measure SRI, so we can estimate the value of our work, e.g. on long-term conditions-wide determinants. We've explored like a social value portal, social value engine. Anything you recommend? Yeah, I mean, I think it's difficult because there's a lot of these tools, and some of them used to be free. A lot of them like charge you now for them, which makes it more difficult to kind of make those decisions because you're gonna have to invest in it as well. Yeah, I don't know. I mean, we've got one in Wales as well that we've developed in Public Health Wales, the social value database and simulator, but we're not sure about what the future of it is. So it's probably likely to be shut down quite soon as well. So I think just how comprehensive they are, really, how much they've got in them, and if you can have an initial explore that they've got things in that are useful to you, then have a look. But I think, is it Social Value UK? There's something that's already got like a repository of different reports anyway that's free to look at. So it's worth looking in that. I'll if you email me, I can I'll send you a link to it, Dougal. So yeah, that's got a lot of stuff in already. But yeah, so it is tricky. There's a lot of these kind of tools out there. I'd say as well, thinking about who's the decision maker that you want to influence, because I suppose you're looking for evidence of similar interventions, and then you want to say that, well, what we do is generating similar social value to those other interventions, but that might not always be the case as well. So I think it's thinking about how robust those assumptions are. I think there's probably sometimes biases with social value things as well in terms of what gets published, etc.
Thanks, Brendan. Any other questions? You can just raise your hand or just say your question out loud if you're brave enough. I'm sure most of you are. I mean, one thing I was wondering, Brendan, is do we know how many or where health economists are working in government and especially I think local government? I think national government, we've kind of got a rough idea of where people might be, and NICE and Department of Health and Treasury in different places. Do you have any handle, or do you think that we need to have any handle on, more local authority level, or not local authority, but at a local level? So in Wales, it's probably easier to keep an eye on things if it's a bit smaller population-wise. But I mean, I'm not saying everyone needs a health economist. I'm just wondering if that need is there. How is it being serviced or fulfilled?
Yeah, I agree. Yeah, I don't know. I think there's definitely not many. I mean, there's Chris Gibbons in Sheffield. He was a health economist, but I think he might have moved on to be more like it's just like a public health consultant or something like that now. Anyway, I don't know if he's on the call, but yeah, I don't think there's that many. But I think there's definitely demand and need for health economic skills in local government. So I think probably what would be good is that if every local authority had like a tenth of a health economist or something like that. I mean, partly maybe that's what the ARC is kind of doing is giving people access to some of those things, and the HDRCs as well as giving people access to some of those resources. But yeah, I do think that it's something that's useful. There's probably public health consultants as well out there who've got an economics background as well, so who can contribute. But I would say I'm sure it's very patchy in terms of what kind of skills are available to people.
Yeah, Alex has just put a comment in there. Did you want to say more about that, Alex? Or
Yeah, sure. Hi, everyone. My name is Alex Milo, and I work for Change Grow Live, which is a leading provider of drug and alcohol treatment, and we're funded through local authorities nationally. I joined from the civil service in 2022. I sat with the drug and alcohol no, alcohol, drugs, justice, and tobacco team in Public Health England before we were OHID. And yeah, so moved in 2022. And this is the first time a health economist has been embedded in our organisation. And just from networking, I'm based in London, but just attending some seminars in the evenings in London. I've met people like directors of policy who are thinking about embedding health economists in third sector organisations. So I think there's a move towards that as well. And it's a really interesting space because it's evidence into practice. And yeah, I don't know, it's just a really interesting perspective, not thinking about government, but thinking about that third sector commissioning perspective.
Yeah, I'd be really interested to have a chat with you sometime, Alex.
Yeah, that'd be brilliant.
I've done quite a bit of evaluation of drug and alcohol treatment services. So I looked at the one in Wirral on two different occasions. I think the second time it was taken over by CGL after I evaluated it. So I don't know if I've evaluated since it was CGL, but yeah, I'm really interested in that. And there used to be quite a lot of tools like health economics tools produced by what was then Public Health England around drug and
Yes.
alcohol treatment services, but I don't know if they're still updated. I mean, I don't think I've got access to the NDTMS stuff anymore, so it might be on there. But yeah, as far as I know, those tools aren't really updated as often anymore. But they were really good and had real potential.
Yeah.
So
I mean, I used to work in the value for money team linked to NDTMS.
oh, cool.
So, that since working at Change Grow Live, I had access to the tool, and I've almost like tried to like break it all down and then update it because I think it was published in 2017, 2018. But yeah, Public Health England did a suite of public health tools, which are still online. If
Right.
people want to access them, I'll find the link and post it in the chat.
Cool. Yeah. The person I used to talk to about them was Ginny Musto, I think, who's now
Yes, my old
Ginny
manager.
writes. Yeah, she wrote. Yeah, so I don't know if she's still working on that kind of stuff as well. But yeah, so yeah, I think there's huge potential. Like people produced a load of these tools maybe 10 years ago, and then they've not really been updated. They kind of sat on the shelf and got a bit old. But I think there's huge potential. I don't know if maybe like NAHR, PHR might fund a program of work to produce these tools for local governments to use or something like that. Or maybe some of it will happen through things like the HCRCs or the ARCs or whatever.
Well, I was just thinking it's something, that our subgroup's just a subgroup for the Northwest, really, but we do feed into the ARCs and the Health Economics national ARC Health Economics group as well.
Oh, yeah.
So it is something, if the need is there and if they haven't been updated, it's something we could actually think about as a project as well to take forward if people would find that interesting and useful. So, and certainly part of the capacity building function of the ARC, please do get in touch with myself or Valerio or Angela is in the MIDAS Health Economics group, and we could even just try and help you put you in touch with people more locally or see where courses are, and MIDAS offers some courses as well, of course, in these areas. So yeah, there's Brendan spot on. There is that is part of the function of the ARCs as well, of course, is to build health economics capacity within local areas, and they're right across the country. Of course, there's a footprint across every region. Hopefully, sorry, Amy, there's a question there as well. Did you want to talk to that one, Amy, or do you want us to read it? Hi, Amy.
Hear me? Yeah, happy to. I was very interested to hear Alex's comments before as well, because I also have a history with drug and alcohol and Public Health England, so our paths may have crossed. But we've just completed a trial and we've got nice economic evaluation findings. And we're in the process of taking those to local clinicians and commissioners, and also hoping to do it on a more national basis as well. But amusingly, a lot of the conversations so far initially, as we've been trying to work out the best ways of communicating this, is that nobody is very interested in a nice scatter plot or a SEAC. And what else could we do? So it's obviously, I mean, it's been a clinical trial, so we've been presenting things in that classic format, but we're now sort of trying to break it down into very digestible, bite-size, pieces of within what I've put in my chat is we're looking at within group changes in resource use and outcomes, etc. But I just wondered if you had seen any good examples of this, or produced even any good examples of communicating cost effectiveness in a non-cost effectiveness speak fashion.
Yeah, I mean, I don't know. I think probably start simple. I'm sure there's a lot of stuff that like pharma companies use in terms of value proposition and things like that. So if you look at those kind of things that they produce, they usually look quite nice, don't they? So yeah, but there's nothing like, I mean, I think if you start simple, start with the results in terms of whatever you've got, cost savings, cost per quality, or whatever, ISA, then and say how it is relative to if it's below a nice threshold or whatever, then that should be a good starting point. And then I suppose what else can you do with it? I mean, if you've got NHS cost savings and things like that, then that's useful, I think, in making the case to some people. And then yeah, I suppose I don't know, in terms of nice visuals and things like that. What else is a good way to show things? But I'm sure like probably pharma companies in terms of value propositions and things like that do lots of nice looking things.
Okay, thank you.
Probably other people on the call might have ideas as well.
Yeah, thanks very much. It was a great talk, by the way.
Thanks.
Okay, did we have a final question? Oh, no, there's lots of thank yous going in, but so Brendan, I'll draw things to a close. Brendan did put his email up earlier. I'm sure he'd be interested if anyone has any comments afterwards, and this will be recorded as well. So you might, and I know a lot of people watch these talks at a later date as well who can't come along at the time. So Brendan, thank you very much indeed. That's really useful. And I think it's such a critical area as well in terms of, health economists being better at this as well. And, and we are, as you said, about academics as well, we are supposed to do engagement better. And we, to be honest, if we want our work to be used and to be useful, I think we just have to do this better. And it's great. It would be great to get some feedback as to how that could happen as well, I think. You're getting lots of comments. Now that I've said we're going, of course, everyone's putting their comments in the chat. So thank you very much, Brendan. I should just also thank Angela Boland and Valeria Benedetto, who organise these talks as part of the MIDAS subgroup as well. And we'll be in touch with everyone about the next talk in due course. And we might see some of you at the ArcFest in a few weeks, he said, forgetting the exact date off the top of his head. Valerio might remember it because he's much better at remembering dates. I think it's the 11th of April.
11th of March.
11th of March, there you are. I was only a month out. 11th of March in Liverpool. We might see you there. So that's great. So thank you all very much for coming along. Thanks to Brendan again. And we'll see you next time.